Welcome everyone to another RACGP Victoria webinar. Tonight we have a WorkSafe Victoria presentation on work-related psychological injury, how to best support my patient. Can anybody hear me? Can we get a little bit of feedback before I launch into the next part? Indications from anyone? We got a couple of yeses. Beautiful. I'm Michael Alfgang. I'm a GP in Victoria out of Metro Melbourne. I'll be facilitating the webinar tonight. We want to make sure that we ask the presenters questions because we don't want them asleep. And we want to make this particularly interactive. Tonight we have the bonus of no visual, but we thought it was more important that you listen. So you will be seeing not us in visual, however, we've managed to create the visual of the slides. So be reassured that we'll be able to go through everything. There will be CME points for this event tonight, 3 RACGP, QI and CPD points, and they'll be uploaded next week. There will be a survey that will be sent out tomorrow, and we'd appreciate if everybody could take a few minutes to answer those questions so that we can improve the service to members. The session is recorded and the link will be sent with the survey and will be uploaded to the RACGPV Victoria website under resources. I just want to cover off on a few technical aspects as well so that everybody's aware, especially if you haven't done this webinar before. And then we're going to get underway. We'll just go through the webinar. We'll just go through a few features of the webinar and we'll give a quick overview of the GoToWebinar panel, especially for those who are joining at the beginning. On the slide at the top, you can see that you've got the web address for technical support if you're experiencing technical issues. Unfortunately, we can't assist with that, so you will need to contact them directly with any of the IT issues that you may have during the session. Next, you'll see that there's a small red arrow. Use that little arrow to hide and unhide the panel whenever you want to type a question. All the people in the audience are muted by default, except for the organisers. So if you have questions, please use that question box. The audio box gives you the option to listen via a telephone line or through your speakers. We suggest that if you are using your speakers, it's probably better to use earphones. If you want to dial in via telephone, select the telephone option and a phone number and webinar ID will appear on your screen. Finally, the questions are there for anyone to ask a question, and we strongly recommend that you use it. We look forward to answering all your questions. Why don't we get started? We've got a polling question to just try and assess the audience. Have you previously attended a WorkSafe and RACGP webinar on mental health? It's pretty hard. You've either got to answer yes or no. Okay, we're up to 95%, sorry, 75% voted. So that means 20% don't know if they've attended or not. Come on, guys. Yes or no, you're not going to get it easier than that. We're not going to get to 100%? Really? 5, 4, 3, 2, we're over 81. Okay, so we've got most people, 95% no and 4% yes. Okay, we'll move on to our next slide. How many people have actually completed the WorkSafe certificates of capacity? Now, again, it's a really hard yes or no question. Let's see if we can get past 80%. Polls are open. We should play beautiful music for you. But no, you've got to listen to my voice. I'm sorry. How many are we up to?
75.
Oh, they're a lot faster this time. We're keeping our little stats on the audience. We're going to get past 80. Oh, look at that. We're past 82. 5, 4, 3, 2, 1. Okay, so what have we got? We've got 70%, 78% are a yes, so nearly 80%, and 22% are a no for completing the WorkSafe certificates of capacity. Next slide. I'd just like to briefly introduce our speakers, and I guess I better go in order. Dr. Ben Barisi is a GP. He's a graduate of Melbourne Uni. He graduated Bachelor of Medicine, Bachelor of Surgery in 1987. He was awarded the RAC GP Fellowship in 2003. He's got over 17 years experience in general practice. He has special interest in sport medicine, assisting patients with work-related injury, helping patients with substance misuse problems. He works in private practice and also as a medical advisor for TAC and the WorkSafe clinical panel. Peter Cotton is a psychologist, clinical and organisational psychologist, specialising in occupational mental health and how organisational environments influence staff wellbeing and performance-related outcomes. He's published a number of book chapters, peer-reviewed research in these areas. He works as an advisor to government and the corporate sector. He's currently a mental health clinician with WorkSafe. He has professional appointments with Beyond Blue and Expert Advisory Panel and SuperFriend. He also works in private practice and with management groups, undertaking a range of consultancy projects as well as clinical and workplace assessments. Dr. Dielle Feldman is a psychiatrist. She's a graduate of Monash University, specialising as a psychiatrist, and dedicated her career to occupational psychiatry. She has many years of experience helping ill or injured workers return to work in a safe and durable manner. She's currently Director of Work Life Well, a boutique provider of occupational health services. Dielle believes strongly in the health benefits of work and appreciates that returning to work can often be an important part of one's overall recovery. She also treats patients both from an assessment role, but also patients who are on claim. And last but definitely not least of our panellists, Priscilla Herbstreit. She is an experienced worker as a psychologist in the workers' compensation injury, having done that for over 13 years. After she completed her Bachelor of Psychology, she joined WorkSafe's claim agents, well, one of them, Gallagher Bassat, and worked in numerous roles, including front-end and long-term case management, as well as being a team leader. Upon joining WorkSafe, she worked across numerous projects in medical and the like spaces, as well as policy and work practice development, agent support and liaison. And she's currently working as a project coordinator within the insurance business unit at WorkSafe. I think we'll kick on to the learning outcomes. So what we've got to do tonight, if everybody's enthusiastic, we want to illustrate awareness of the vital role of GPs and health providers that they have in the treatment and recovery of their patients with work-related psychological injury. We want to provide practical tools and strategies to assist GPs with assessment of work capacity, certification, and return to work for patients with psychological injury. We want to provide information about the supports that WorkSafe offers and how to access them to assist your communication with employers and with the injured workers. We're going to start off with a case study of Kim.
Thank you, Michael. Dr. Ben Baresi here. Welcome, everybody. We thought we'd start the webinar with a case study, and the panel will discuss some relevant issues relating to this. So this is Kim. Kim is a 45-year-old single woman. She's been attending your clinic for 5 years. She works as a call centre operator, working for a large company. She presents towards the end of her annual leave saying that I can't return to work due to bullying from my manager. She requests time off work and wants to put in a WorkSafe claim.
I think this is DL Feldman here, psychiatrist. I think this is a really interesting claim and one that I see the scenario happen a lot in, especially when workers present after a period of leave. That's a high-risk time. They've had a relaxing time on holiday. They see the contrast to what it felt like compared to when they're at work, and it's a time when anxiety can escalate. Worth making that point.
Thank you. We'll move on to the next slide, which is a polling question. So at this point in time, we have 4 alternatives. Alternative A is provide a certificate of capacity for 4 weeks off. B, complete a mental health care plan. C, take more of a history. And D, call your receptionist and say that you are going to run late. So I think that's probably a point that we can see that this is going to potentially be quite a complex situation. So take some time to answer the question.
Okay, how many are we up to? Hey, we're getting a pretty quick response on this one. Come on, guys. We're not up to 80% yet. Ah, cool. Come on, a couple more. 5, 4, 3, 2, 1. Okay, we'll go through the answers.
Well, I'm reassured to hear that not many people know. People, in fact, are writing a certificate for 4 weeks off work. I think that a prolonged period of time off work is problematic for many reasons. I think, first of all, there's a risk that the patient might not represent for treatment or as further assessment in that 4-week period, which is obviously a time when treatment or further assessment is most indicated. And I also think that there's risks with being off work for that long. You're setting up expectations of a delayed illness, and just like the anxiety at the end of the holiday, I think anxiety after 4 more weeks off can really escalate and fuel those avoidance behaviours.
Yes, and well, exactly. The avoidance can be really challenging and make the condition worse. So much shorter time off work, and we'll come back to that in a little while.
Okay, so you now ask Kim for some more additional information. She tells you that she's got a new manager who only came on board a couple months ago, and in her mind, or she believes that the manager is micromanaging her, and constantly checking up on her work, standing over her, looking for her whereabouts. Even if she goes to the bathroom, he notices. She says that he's criticising her work in front of her colleagues, and that's making her a bit self-conscious and anxious, and he's treating her generally differently to how she feels he treats the other staff. She's very distressed and tearful as she's relaying this to you, and as she's speaking, you sort of have a brief look through your records, and there's no prior history of mental health issues noted.
I think Peter Cotton here, one of the challenges here too is, of course, we have to validate our patients' own experience, but we have to walk a line in being cautious about thinking or making attributions about the workplace. I, a little while ago, saw a certificate that after a 10-minute consult had institutional bullying, remove the manager before my patient comes back to work. That's a little bit of a big call to make on the basis of one 10-minute consult. So we have to be careful about sort of unwittingly moving into that excessive advocacy role.
I think the other point to make with this slide is that about the new manager, and in my experience we often see people present the new manager, and it's really important to tease out, you know, is it a problem with the actual manager, or is it perhaps that the manager beforehand was a little bit laissez-faire, for example, wasn't keeping a close eye on the staff, and then a new manager comes in and has really rigorous expectations regarding key performance indicators, for example.
Still might be a workplace problem because that transition might be a bit abrupt, so there may be issues in the workplace that the workplace should be addressing.
Absolutely. So moving on to the next polling question.
So, are you inclined to fill out a certificate of capacity at this point? We've got 3 answers. Yes, no, or you're not sure, you want a bit more info.
I think most of us agree that we need a little bit more information.
Yep. So we'll move on to the next slide. So you proceed to ask Kim some more questions. She reports to you that she's been feeling sick in the stomach since her manager started. She can't sleep. She's lying awake at night worrying about the manager. She says that her Saturdays are good, but on the weekends, on a Sunday night, she feels dread. She sits in the car before work. She finds it hard to walk into the building. She feels edgy sitting at her desk thinking that her manager is watching her. Her mind is racing and she is tearful at work. So we'll move on to the next slide.
I just want to, with this slide, I think this is a really common presentation that we often see, especially the feeling better on the weekends. I think that's a sign possibly of that the mental health isn't that severely affected and that it might be related to the work stresses. Also, the Sunday night dread sort of feeds into what we were talking about before about when you're away from something, then the avoidance and the increased anxiety and escalation.
Thanks, Deal.
So you then ask Kim more questions to get an understanding of her functioning and behaviours rather than just her symptoms. She tells you that she's absolutely exhausted after work. Being there just completely tires her out. She essentially just collapses on the couch and she's no good to anyone, can't even do household chores. Normally she loves reading a good novel, but at the moment she can't concentrate. She's distracted by what's happening at work. She can't even get to the end of a page and remember what she's read. She's not going to the gym anymore. She's too tired. She's stopped seeing her friends. She's starting to feel alienated from her work colleagues, feeling that they're not supporting her. And, you know, previously she enjoyed a very rare glass of spumante, and now she's started drinking a couple of glasses every night to help her get to sleep and manage that anxiety.
And I think, Dale, what you're indicating there too is that it's the functioning that's critical, focusing on what the person can and can't do, and also highlighting, identifying any harmful behaviours, potentially self-medicating with alcohol, which is often quite common for people. So we need to look at that and try and minimise that.
Some more questions. What is your diagnosis? Is this no diagnosis, just a normal response? Is this an adjustment disorder? An anxiety disorder? A post-traumatic stress disorder? Or just simply work-related stress? What do you think?
So it's Priscilla here. Just on the point of the work-related stress diagnosis, we would often find that an agent would find that particularly difficult to work with as a diagnosis. We find that a very broad statement, it's similar to if someone were to write a back injury on a certificate. So I think from an agent perspective, we would certainly find that a challenging diagnosis to actually work with, and you'd probably find that you'd be asked to re-clarify that to make it a lot more specific. Would that be something that you would agree with?
Yes, I think it's Peter here. The diagnosis needs to be accurate, but there are some challenges here as well, because what we tend to find is at least a third of people in this mental injury, psychological injury space, it's more about low morale and a poor person job fit, square peg in a round hole type phenomena, rather than a medical diagnosis. So one of the risks here is that we can over-medicalise, versus we also want to validate our patients' experience and legitimise their time off work. So there are some challenging issues in this space.
we want to talk a bit about post-traumatic stress disorder as well and the diagnosis of this. Peter, what are your thoughts about diagnosing post-traumatic stress disorder in this situation?
Very, very good point. It's commonly very overdiagnosed, particularly if you happen to work for emergency services. The challenge in the bullying space is very apparent as well. So often I'll have discussions, well, was the manager who's the alleged bully, was he or she actually standing over you with a gun or a knife pointing at you? There needs to be that life-threatening element. So there are some diagnostic possibilities, and sometimes it's better to say there may be features of traumatisation, but the threshold for diagnosing PTSD is quite significant.
So we're kind of saying that the diagnosis has to be as per either the DSM or the ICD. It has to be an actual diagnosis that needs to fit that criteria.
Well, I think that's in WorkSafe, workers' comp, legal jurisdictions, it has to be a recognised diagnosis. So they're the two reference points that are generally accepted in Australia, aren't they, for mental health.
I just want to give a bit of feedback. We had 31% of people said work-related stress, 0% said PTSD, 17% said anxiety, 6% had no diagnosis, and 46% said adjustment disorder. And I guess for me as a GP who lives in a world of continual adjustment disorders, I really find that interesting because it's basically practically managing everything pretty much in my workspace. So I thought I'd throw that back to the panel and see what you thought about writing that adjustment disorder that's a very non-specific diagnosis.
Look, it is a very commonly used diagnosis, but sometimes it is the diagnosis that fits best. I think that when diagnosing adjustment disorder, the challenge is having to think about whether their reaction is a reasonable reaction to life stresses, or whether it actually goes beyond that to a pathological reaction, one which impairs functioning and other domains of life. So I think for me that's the distinction in determining that diagnosis. But I don't inherently have a problem with that diagnosis being made. In this example, it's not a bad diagnosis to give with features of traumatisation, perhaps. What do you think, Peter?
I agree with your points, but from where I sit, we see it as it's a massively overused diagnosis, and a lot of people I see, I guess getting back to one of Michael's points there, that it seems to me that it's a pretty reasonable reaction, being a bit upset in response to a particular situation. But it is a legitimate diagnosis, so therefore it has a status. Effectively, it's a bit like the new stress. When we stopped accepting stress as a diagnosis, adjustment disorder's been a replacement for it, because it is fairly loosely defined.
But I think we do, as you say, we do have to be careful not to medicalise, for example, industrial issues and put them down that framework with that diagnosis.
Indeed.
So one of the things that people in the audience are thinking about is that though you're particularly impaired in your day-to-day activities, when does it actually qualify as a disorder?
Well, diagnostically, it's about reaching a clinical threshold, so it's about the severity of symptoms and the impact on functioning, and you have to meet a range of criteria.
But I think, with a lot of psychiatric diagnoses, it is a lot up to clinicians' perspective, so it is a bit grey. But there has to be a change in functioning that's in excess of what would normally be expected. Like I would expect someone to have some sleepless nights and some anxiety in the setting. If she becomes housebound and bedbound because of it, then that's more of a
Excessive, yes.
Yeah. So there's a judgment call in it.
Function.
Okay, so the next thing we do is we ask him more about her functioning at work, and I think this is a really important thing to do and something that we don't often always do. Sometimes we just rely on the patient's self-report, but I think it's really important to try and get some more objective measures of how she might be functioning at work. That's going to be important for a range of reasons, including setting up return to work expectations. So she tells you that she's finding it much harder to concentrate at work because she's so preoccupied and wondering where her manager is at all the time. She's so fearful of making a mistake because she's scared she's going to be hauled over the coals. So she's checking and rechecking her work. It's taking her longer, therefore, to complete her tasks. She's starting to paper shuffle, procrastinating over her work tasks. She's going to the toilet 2 or 3 times a day to have a bit of a cry. You ask her specifically whether there have been any performance issues, and she just kind of brushes it off a bit, telling you that she's had a few chats the year prior about her KPIs, but everyone's had the same problems.
Just one general point, Adele, Peter here again. The emphasis on functioning is really critical, because what we find is that by virtue of being mental health, that we often tend to have more latitude. Mental health professionals tend to focus more on symptoms, but at the end of the day, it's the functioning that's really important. How does the lack of concentration actually affect what the person can and can't do, how much they can read, etc., etc.
KPIs are key performance indicators. I don't know if that answers somebody's question.
I'll lead to the next question, on to the next slide, which is another polling question. So what do you do next? So point A, do you endorse a workers' compensation claim? And B, do you provide a sick certificate and book another appointment? So again, in general practice, that's sometimes logistically a reasonable thing to do. Point C, do you give her the details of a good lawyer that you know? Point D, ring the front desk and ask where your lunch is. Clearly we're dealing with a fairly complex situation here that takes a bit of time. And point E, ask the patient for permission to speak with the employer. So I suppose a few talking points around this polling question. It's obviously an individual's right to submit a workers' compensation claim, and there's various resources out there to support workers in this space. Sometimes they don't feel like there's any other alternative. So
it always has to be their choice.
Correct. About point C, I'm personally not sure that that's where I would head with this at this point in time. There can be a bit of a problem for involvement at this particular phase, because we're trying to sort of develop a good relationship with the employer and try and get the patient better. So that can be a problem at this particular point in time.
Just on that point, I'm always hesitant to first of all, I don't think it should come from me, but I'm hesitant about lawyer engagement so early. I think while there are some situations where there's no other choice, like more specifically later on, I think I've seen lots of cases where early engagement with lawyers can cause significant difficulties. For example, I've had lots of patients who tell me they went to the lawyer and the lawyer said, stay home for the next 6 months with your blinds down. And I know that's not uniform the way it works, but I've seen enough of those cases to make me a little bit concerned.
All right, we might close the voting on that one. And 13% would lodge a claim, 57% would provide a sick certificate, 2% would give the details of a good lawyer, perhaps they're married to one, 2% would ring the front desk, and 27% would ask patient permission to speak to their employer.
We'll move on to the next slide, which is contact with the employer. So
that was our preferred option then, suggesting?
Well, there's certainly a percentage of the audience who have said that that's something that they would do.
I think in real life, though, we can do more than one, so we might provide a sick certificate, book another appointment, and ask permission to speak.
Indeed.
So again, this does raise some questions. So obviously there's some privacy concerns that I know a lot of my colleagues would have if they were discussing a patient's issue with their employer, whether we do that with the patient present or not. And one of the challenges is that you might make the call during the consultation, but the HR contact might not be available, or they might feel that they're a little bit unprepared for the phone call, for example. Do you do it as a teleconference? Do you have the loudspeaker on so that all three people can discuss the situation? And there might be other information that becomes available. So it's important to think about those things, isn't it?
Yeah, and just a couple of thoughts of privacy issues. I suspect we all always ask our patients, what are they happy with us disclosing? What are the specific things they don't want us to disclose? Documenting that and then documenting the teleconference when it happens. With the teleconferences, I find it always challenging whether to have it on loudspeaker, face-to-face, or just privately between the workplace. I think ideally transparency is always best, but there are some situations that have caused me some problems. For example, just a week ago I had a case conference with a worker who had felt that they were a superior, amazing worker. All their self-esteem was tied up in how well they'd done their job, and they came crashing down because of overwork in the teleconference without us expecting at the workplace that actually they've been a very crappy worker, and I could just see my patient fall apart in front of me, and then there was a significant amount of damage control. So I think before we decide how to do it, there needs to be some thought into the potential benefits and the potential risks.
These are really good to do in a routine general practice consultation when you've got a full waiting room. And I dare say part of what you've got to think about when you are a GP is actually allowing the time for these sorts of things. And that's pretty important. I'm sorry to throw that all in, but
it's a really important point, and double appointments, I'd imagine. Ben?
Well, I think 57% of the audience said that they would give a sick certificate and then book another appointment for the patient, which is another good time management strategy. It gives you an opportunity to, you know, perhaps digest some of the information that you have and maybe give the patient a little bit of time to consider some of the early points that you've made. So,
and certainly in the case of the accepted claim, that there is the GP case conference option, which can actually be pre-booked ahead of time. So that would allow that time to, I guess, get your head around the situation and what you can and can't discuss in that time. So that's certainly something that is available to accepted claims.
And in relation to the feedback from the employer, I think obviously in alluding to DL's example, better that may be provided directly to you, perhaps without the patient present. But as I think Ben's indicated, otherwise we might negotiate with the patient and clarify what we will talk to the employer about. But that feedback's important too, because what we want to do in response to that is look at is there any longer term underlying anxiety condition that may be responsible for that? Is there any cognitive decline? So we might want to look into this a bit more to see if there is any health issue overlapping with performance issues, because if there is a health issue contributing, then the employer should not proceed with standard underperformance management. There's an obligation to make reasonable adjustments.
And sorry to make it a bit more complex, but there's also issues of underlying capacity. This is a woman who was never really able to perform her job that well, but kind of just went unnoticed until the new manager comes on, and that's going to be important in return to work planning too. But anyway, with Kim, we get our feedback, and she's had long-standing performance issues. She's spending way too long on telephone calls. She's not signing off and completing her work. And the employer also tells us that she's had 25 sick days in the last year, and that's interesting to us because we've only given her 3 sick certificates for 3 days off in this year. Do you want to comment there?
Yeah, so that's that would be news to me, given that this patient has come to the practice for 5 years, and you've only got in your books that she hasn't had that much time off, and then you get information to say that there's been 25 sick days supplied. So again, that would raise some questions that you might have to consider.
And I don't think it's an uncommon scenario where someone who wants a sick day just goes to the local bulk billing GP next to their house rather than their long-term GP. But I think it raises the issue that we need to be asking our patients these questions.
You don't have to go to the doctor, you can go to the pharmacist to get the certificate.
Stat Dec or?
Certificate. Go to the physio. Anyone, if they're an allied health professional, they can give out that.
For a mental health problem, Michael?
Well, we're not talking about a work certificate here. We're talking about sick day.
Yeah, right.
So this leads into the hoary old chestnut of doctor, should I lodge a claim? And as we've already alluded to, that decision must be the person's own decision. We want them to be well informed. There are some pros and cons. On the benefit side, there's obviously income replacement, financial while the person's off work, treatment costs are covered. So if someone's on a mental health plan, say with a psychologist, they'll get 10 sessions under Medicare, but they may need more treatment, and this will ensure that that's covered. There's rehabilitation support, and some people often believe that having the claim accepted sort of is just a sense of justice or vindication that in terms of their relationship with their employer. On the other side, sometimes there's a perception that things will become adversarial, and sometimes they do appear to. The person may be referred off to independent medical examiners, and that's a whole other area. And of course, some of the issues raised there, and whether that IME has a different view than your own GP. I've seen the patient for 15 years, you've seen them for 1 hour, so we get those sort of challenges. And the feeling of obligation to prove that I'm ill and have incapacity. There's often anecdotes about people fearing that we try to encourage them to do, maybe volunteer work as a step forward, and they're fearful that there'll be surveillance. So there's a lot of challenges in this space.
I think it's probably important to note, Peter, that it may be perceived as an adversarial process, but we're of the encouragement if somebody does have a genuine entitlement to claim, that we would always encourage that. There might be some, I guess, adversarial steps, such as an independent medical examiner that we know that can often pose some issues there, but certainly we would be encouraging people to lodge where it is practical and I guess right to do so. So although it may be perceived in that manner, it should be deterred.
And look, just to note as an aside, we do recognise it can be very stressful, particularly for people with mental health issues. WorkSafe does fund a number of initiatives, including ongoing research about the experience of the claims process, and looking at a range of initiatives to try and smooth the way to make that less potentially stressful.
I think just on the topic of IMEs, I think a lot of them these days are pretty reasonable, but am I right in understanding that if there is concern about a particular IME examiner, you can request another one if issues such as time permit?
If time permits, and if a person has a genuine issue with the particular examiner that they're going to see, then absolutely talk to the agent and the case manager about that. That's certainly not a problem in getting a suitable alternative examiner where it's appropriate to do so.
The other issue I think is really important to raise is this idea of reasonable management action, and I'm not sure how many GPs are aware of this, but in the legislation it says that even if a worker has a psychological injury from work, if it's perceived to be due to reasonable management action, so that can be normal performance management, then the claim's not accepted. And so that can cause difficulties for the patients when they think they're legitimately unwell, and they might be, and their claims declines. It can also cause difficulties because in the response to the work cover claim, the employer most oftentimes gets the right to reply, and in that reply can be a lot of issues that the patient might not have known about, such as difficulties with their performance behaviour, and reading that, I've seen that escalate patient symptoms.
It tends to be polarising.
Yeah, very much so. And, I mean, in my view, I think it's really important that we arm our patients with this knowledge beforehand. So if there's lodged a psychological claim, you are likely to have an IME. There is this issue of reasonable management, for example, so that when the process actually occurs, they don't feel vindicated or that they're being treated differently, for example.
And Priscilla, am I right in saying that the employer has an obligation to provide the worker with appropriate information that they can, like brochures about the workers' compensation, etc., and they can also ring WorkSafe Advisory?
Yeah, so generally if the worker had I guess a concern about the lodging of the claim, then there's obviously quite a lot of information on our website that can be accessed, but equally there is the advisory line that they can call, and particularly in the context of management action, that is quite a complex area, and it does involve ensuring that a reasonable process has been followed by the employer for issues such as performance or relocation or change of duties, and so that can become a bit of an industrial relations type issue, and so I would encourage a worker, if they were a bit unclear, to access those resources to get a better understanding of what that meant for them in their claim. Basically,
advisory provides straightforward advice,
yes,
factual information. They're not advocating WorkSafe, and it can be confidential. You don't have to tell anything if you want to ring up and find out information.
That's exactly right. No, they're absolutely impartial, and they're more of a knowledge centre for people to access if they need to clarify that point.
Can GPs call as well?
Yes, yes, yeah.
Okay.
So moving on to the next polling question.
Okay, so do you complete the certificate of capacity now? And this is again a really hard one. Yes or no? While you're thinking about it and you're still polling, somebody's asked a question, can a GP ask for another IME?
A second IME?
Yeah, is that a GP's?
Can you, if you're not happy, you mean if you're not satisfied that the first IME was independent, can you ask for a repeat IME?
Yeah, that's what I think the person means. Okay.
I think it would be something that, I mean, I'm not quite clear around the question of how they would determine that it wasn't or was not independent. We certainly would have the option for a doctor to flag with us whether there's any information within the context of an IME report that they think is clinically inappropriate or not appropriate to report on. We do have a review panel of IME reports where we do find that a doctor might not have been impartial in their assessment. So we would certainly encourage instances of that to come to us so we can identify that. If it is absolutely apparent that something has gone awry, then we would certainly work with the agent and the worker in that instance to work out a strategy on how to manage that particular examination. But we certainly could arrange for another one where that has occurred, most definitely.
WorkSafe does rigorously review any complaints about IMEs and follows them through and provides feedback and works with that IME. And there have been IMEs that have been asked to conclude their involvement as IMEs due to recurrent poor feedback about issues.
Okay, we'll close the poll now, and we still can't get 80% of people to vote. But we've got 56% saying yes and 44% saying no. Any comments from our panel?
I just wish we knew everyone's thinking.
Yeah. I think it just shows that, yeah, there's obviously a lot of grey areas in this space which require a lot of judgment. I think we've talked about that previously, and I guess as we move on, I think that will sort of become a bit more of a
And the reality is that with your own patient, you probably have more context and know them better than a little bit of an abstract case study, so that always makes a difference.
So we'll move on to the next slide. So I've actually put a certificate up here that I've completed. So I know we talked before about, is it an adjustment disorder, or is it an anxiety disorder? I've listed anxiety disorder as a diagnosis. And again, I think that just comes down to what your level of judgment is with the types of symptoms that the patient's reporting, her level of function. I know we've discussed that earlier. So I've gone through and completed the physical assessment of capacity where there are no limitations. But I think if you look on the left-hand side of the screen, you'll see that there are some comments made about the worker's mental health function. So if we'll move to the next slide. So here, I've ticked in the mental health function area that attention and concentration are affected, memory's affected, and her judgment is affected. I've listed next to that some more additional information, which I think is useful to do, and I've written that it will take her longer to complete tasks. She has some difficulty in making decisions in the workplace, and that she needs some short breaks whenever she goes to work and actually undertakes her tasks. Also moving down to the work environment considerations, I've listed that requesting a change of reporting line to not be performance managed while being treated for the condition that I've listed there, and to provide some regular feedback to her about how she's going, but on an informal basis for a period of a few months. So
just clarifying that point, I think there's a lot of workplaces out there that say unless the person can be performance managed, they're not fit to be at work, and I think that's due to a fear that they're going to have someone in their office who they can't give any feedback to. So I think if your couch can't be formally performance managed but can still be given feedback supportively, that often is enough for the employer. In terms of the temporary requesting a change of reporting line, obviously some organisations will be better equipped to do it than others, especially the larger ones. But I think unless we ask for it, we don't get it, so it's worth asking for things like that. The other point that I'd maybe put on that slide is, you know, we can request things like increased training or retraining if necessary.
And I would agree that that is a really critical piece of information, particularly from an agent point of view, to be able to facilitate appropriate services to that person, and with the context of modifying workplace or making reasonable adjustments, having that information there will really steer that in the right direction and really help facilitate that return to work. So I guess we can't stress enough the importance of getting that section completed and making that available. Yeah.
Can we just digress for a minute, because we've had a few questions, I think, about knowing more about IMEs. I'm not quite sure what's being asked, but just in terms of, from a psychiatrist perspective, to be on the work cover panel as a psychiatrist, you have to have been in clinical practice for at least 5 years, and you have to have 2 referees supporting you. You have to demonstrate, you know, sound clinical judgment and report writing skills. Most IME examiners would spend, I would hope, around an hour assessing an individual, asking a range of questions, and then furnishing a very detailed report and answers to questions.
Yeah, and they go through a fairly rigorous process of being vetted at the WorkSafe end, and WorkSafe's particularly concerned about issues of you know, ensuring that the opinion is equitable. There's no indications of bias or slanting of the opinion, and that they're mainly used by the agents for 2 reasons. One is initial liability determination. Is the presenting clinical condition significantly linked to the workplace, or is it pre-existing, or it's there irrespective of what's happened to the workplace? And often to review treatments, because sitting on the other side of the fence, we do often see instances where, I'll talk about my own profession in the psychology world, people don't manage the expectations, and people settle into sort of an ongoing, very supportive, empathic sort of relationship that ends up being open-ended, and people can develop expectations of staying in that for ad infinitum. So that's a brief few comments on the role of IME.
I think another thing to note is that the IME examiners are often sent information, which might include the GP progress notes if they have access to them, and workplace investigations and other information. And I'm the understanding that you can give your patient some information that they can take to the IME examiner for their consideration as well.
All right, we'll follow through with the further area of the certificate, and that's around certifying capacity. So just a couple of points to make here, that this is really important in terms of also starting a conversation about capacity and return to work. We'll say a little bit more about that at the moment, but we know that setting clear expectations is critical. Again, I'll note that we do see a tendency out there, and this is with a bit of a sort of beyond blue hat on as well, that because it's mental health, we tend to allow more leeway, more latitude, but paradoxically, people in the mental health space with mental health conditions progress better, function better in terms of longer term outcomes when we do have clear-cut expectations and parameters. So the freewheeling sort of open slather approach ends up often becoming counterproductive. We'll also note starting the conversations can sometimes be a bit awkward or challenging. So one resource we draw your attention to, and there is a listing of resources at the end or in the pack that you have. It's called Conversation Starters, and it's practical examples around GPs actually initiating this type of conversation with their patient. The final issue to note is around, we do find that there tends to be an either-or, in the sense that it's either the person's totally fit or totally unfit, and we do encourage you to recognise the shades in between. So, for example, partial certification, and the example we were talking about before of Kim, I think, of certifying where a different reporting line, etc. So we can certify the person's partially fit rather than wait for another several weeks till they're fully fit. They'll have a much better long-term outcome if we help them to dip their toe in the water as soon as possible. Because the other issue is that the longer they delay, the risk is we'll be reinforcing the avoidance behaviours, as we've already talked about.
I think the other point is, if we do say set a return to work goal, that can always be changed if needed down the track.
If I just like to Ben Baresi again here. Obviously, that's a very difficult conversation to have, but thank you for helping us with that. There's a question regarding the certificate of capacity that some GPs are a little uncertain where to find it. So Most software packages, so best practice medical director, will have a template for you to complete, which generally auto-populates, so you don't have to write in the patient's name, date of birth, address, etc. So that usually is something that's standard with most software packages. Alternatively, you can go to the WorkSafe website, so worksafe.vic.gov.au/certificate. You can find a template there.
So we put this slide in because I think it's useful to just have a think about what does it mean to be fit for work, because while we're saying let's have a discretionary element and let's try and get Kim back to work in some capacity, we certainly don't want to get our patients back to work if they're actually not fit. The way I think about fitness is pretty reductionistic and simple, because I like to keep things simple. I break it into 4 different sections. The first one is about attendance and punctuality. So can my patient attend work regularly, reliably and sustainably? So not just for 2 days this week, but on an ongoing basis. Then I think about performance. Can my patient perform with reasonable quality and efficiency? Now, if I think they've got impaired concentration, for example, and they need to check and recheck their work and therefore their efficiency is going to be slower, I don't mind that so much because I can suggest lower key performance indicators, work at half capacity. But when there's issues with quality that I think they're making mistakes and won't fix them, then I'm more likely to deem someone unfit for that work type. The third thing I consider is code of conduct. Is the person able to abide by the code of conduct? Can they behave appropriately in the workplace? And that's more obvious sometimes for conditions such as mania or psychosis, but sometimes in these traumatic impediments as well. If this woman, for example, Kim's got major problems with their manager, can she contain her emotions enough to have an amount of civility in the workplace and not affect the other people in the workplace? And the last thing I think about is the occupational health and safety risk. So in my mind, to be fit for work, work can't make the person more unwell. And with Kim, we've written a certificate to address the factors that are making her more anxious, hopefully.
So it's Priscilla here. I'll just talk about workplace reasonable adjustments. The legislation requires an employer to provide suitable or pre-injury employment during an aggregate period of 52 weeks of incapacity. So there's been some suggestions here on the slide which talks about some of the adjustments an employer can make to accommodate a worker back to work within that 52 weeks, and some of those might include providing modified or suitable duties that are different to pre-injury, reduced hours or working on a graduated increase in hours, expectations in terms of their KPIs or time frame of completion of tasks, and possibly an alternate line of management, which would obviously, as we talked on before, is sometimes not always possible, but in some employers it can be possible. So to make the employer, I guess, their role easier in the process in terms of offering those suitable duties within their legislated time frame, things like that to be considered and mentioned within the context of the information you're providing is extremely important. And we talked earlier about that in the certificate area, and that's certainly where we would like, the information about that would be suitably placed. I'll go over to the next slide.
Before we do, we have a very good point made by a colleague here who has made mention on the treatment plan on the certificate of capacity that there's a concern about a breach of privacy with the reduction of alcohol. So again, that's a very good point. I guess what we're trying to do is outline a treatment plan on the certificate. The amount of disclosure that you put on there is probably a judgment thing, and that's obviously something that we would encourage to use your judgment there. I guess what we're trying to promote is healthy lifestyle factors there.
It's also separating that if there is a factor that's affecting health and return to work progress, we may mention that it's a barrier, but we want to separate that from any sort of social judgments or other prejudices about alcohol. WorkSafe treats that sort of information respectfully, and it is about barriers and progress to return to work, so full stop.
There's a question that's been asked about fitness for work in a pregnant woman who's taking time off for morning sickness and is feeling discriminated by that. I think that's an interesting question, and when I went through the Fit for Work slide, I was talking about psychiatric fitness. So I think first of all it's important that we try and separate illness factors from industrial issues. If it's getting to the point where it is causing her symptoms or functional impairment significant enough to be problematic, then I think it certainly needs more unpacking. bit more about the nature of the discrimination. But I think the first step would be working with the workplace to try and increase their understanding of the situation and trying to pave a way forward that way before going down another avenue.
I've got a couple of interesting questions that I want to put to the panel as a little interruption here, and they can think about them before they answer them. We're not going to give too much hassle here. If the condition isn't accepted as being work-related, some employers still want a work cover certificate and will help with modifications of duties. So that's one statement.
It's easy to answer, Michael. In this day and age, if you're a large employer, you have more non-compensable cases than compensable cases, so people still have physical and mental health conditions without a compensation claim, and the sort of general recommendation is managing in a parallel way, so having a plan, even a rehab provider, etc. So in a parallel way is the way to go, ideally.
So that's a good HR department is what you're
Yes.
suggesting
But you
there.
wouldn't necessarily have to put it on a work cover certificate.
No.
You'd write a treating doctor's report.
So it's called a supported employer.
Yes.
And there's more and more of them because they're realising the cost benefits of keeping their employees at work and well, irrespective of whether it's work-related.
Thanks to God. And then the next one, which is an interesting question, how would you manage a situation if the patient isn't agreeable to the GP recommendation on returning to work? Don't all be silent.
We're thinking.
You're thinking.
All right, we'll let you do the 5-minute quiz.
Well, you just. Oh, sorry. Do you want us to make a couple? Well, I think you do need to think in terms of certifying on the basis of capacity. So we've got a slide a bit further on which talks about other influences on certification. But maybe you have to have a confronting conversation with your patient in that direction.
I think ultimately you're providing your opinion and signing the certificate. So that's really it is a challenging discussion to have. But if that's what you truly believe that the worker has got a capacity, then I would urge you to stick to your opinion.
I think also you need to understand the reason for their reticence to go back to work. Maybe there's other barriers there that need to be addressed that haven't been addressed. But if we think that the person's it's a lifestyle issue or a motivational issue and not illness at all, then I mean the other thing I say is this is a medical legal document. Like I'm legally obliged to write, what I think is very reasonable. I can't perjure myself.
Indeed.
Okay, so moving on.
Setting expectations. Now, this sort of elaborates a little bit on a slide a couple of slides ago. I won't read all this out in detail, but perhaps highlight the bottom point that where the healthcare provider has contacted the GP's workplace, this research indicated they were twice as likely that the injured worker would get back to work earlier. So establishing that contact, building that sort of relationship. But again, it's all about setting some clear-cut parameters, setting reasonable expectations, helps with the return to work, not just leaving it open slather by virtue of it being mental health.
Agree.
So next slide is again reiterating some of the points we've made, but one of the key points I wanted to highlight here was simply that in the research undertaken, and this includes via WorkSafe funds and more ISCA, the Institute for Safety, Compensation and Recovery Research, based at Monash University. They have a whole range of projects, research studies going with injured workers across a number of jurisdictions. But a lot of individuals certified as unfit, and it's nearly half of them actually do have some work capacity. So that, going back to what we've already said about that partial certification, that's much better in your patient's longer-term interests. So shorter periods of time off work, because longer periods of time off work do carry a significant risk the longer and longer it is of becoming counterproductive and reinforcing that avoidance behaviour. Oh, and here we go. So this is the, we mentioned before about influence on certification. So it seems like, and this is surveys run with GPs, that when you unpack the influences around feeding into certifying, judgments about the physical capacity of the person still loom large, even in the mental health space, taking into account the person's willingness. So that goes back to the question we were just addressing. Willingness is not actual capacity. So sometimes I find myself when I'm doing assessments talking about the difference between substantive capacity and perceived capacity, which may be more influenced by motivation and willingness to return or not to return. The relationship with the employer figures in about 1/3 of cases, and for some reason a smaller number of people actually also take into account status of relationships on the home front. So, but there are multiple factors there, but again, going back to the points I think both DL and Ben made, that ultimately it's your judgment, and you really have an obligation that it's accurate based on clinical assessment. You're the one signing the certificate.
Can I just interrupt? There's a question here about what factors will take into consideration in determining workplace bullying as the causation factor if the mental health symptoms in the midst of other symptoms due to a pre-injury, other comorbid conditions such as a pre-existing anxiety, depression or PTSD. And I think the answer to that question is it is very, very challenging. A lot of people who lodge a claim do have a pre-existing illness. It doesn't mean that their claim's automatically written off. For me, the things that I look for as an independent medical examiner is there a temporal relationship of a significant worsening of their symptoms and functioning. So they might have had depression, anxiety and PTSD for many years, but they were managing well at work. Then something happens and they deteriorate significantly. And obviously you also look for other factors that are going on. Keep in mind that the Work Cover Authority and the IME examiner will probably have access to your GP progress notes, so if it's riddled with things about other major personal stresses, then that will be identified, and I think that's an important thing to let your patients know.
The other point to what I want to add there, DL, is the fact that someone has a pre-existing condition doesn't mean that they're not bullied in first instance. Yeah. And one of the profiles I often see is where the person has a genuine mental health condition that is associated with some adjustments and some issues around performance. And what you see is a common profile I see is where it's a fairly task-focused manager who provides a sort of level of tolerance, but then ends up getting frustrated, perhaps because they're under pressure for churning out the KPIs. So they actually end up, in a substantive sense, becoming a bully because they start hassling the worker who has those limitations.
And I think in those cases what we've got to be careful of is this idea of reasonable management action, and then we look at capacity. If it is a long-term illness and they're not performing effectively, is that going to change our end-locational goal recommendations? Do we need to look at alternatives?
Because from an employment point of view, I mean, sometimes people do move into a space where they're no longer able to fulfil the, in the jargon, the inherent requirements of the job. So sometimes people do leave work under medical ill retirement, or maybe they go part-time. That's a better option for them to maintain their engagement with work.
Thanks, Peter. It's Priscilla here. So I just wanted to talk a little bit about the claims process and how that works. So once a claim has been lodged, the managing insurer will actually contact the patient to discuss the next steps of the process, which may entail a few of the things we discussed earlier, such as the independent medical examiner or another form of information that they might need to assist them in the claim. And that will also may include asking you to complete a questionnaire, and that information is really pivotal to the agent because that allows them to get your version of events as well, and also give them some context to it from a clinical perspective as well. And again, there might also be a reason to ask the patient to provide a statement around the circumstances as to what happened, either at the incident or over a period of time. And then if the claim is rejected, the patient does have a number of options available to them. They can actually ask for that decision to be re-reviewed again by the agent. They've got the option of conciliation as well, so that they will be notified of that if that is the case.
Just a point on that. And I see so many GPs who write certificates saying unfit until the work cover process is sorted out. And I think there's an expectation at the beginning that that's going to occur within 28 days, but when they do go to conciliation, for example, my understanding is that it can sometimes be drawn out quite a while. So keeping someone unfit, off work, unfit during that process, I think can really feed into increased preoccupation and focus on what's happening and really result in worse health outcomes. So be mindful it can take a long time to sort through.
It can. The conciliation process is certainly not a quick process, and I think there, as I've mentioned in here, it is really important, regardless of the outcome, to continue that engagement with the patient and treatment. Peter mentioned earlier about the Medicare sessions and a few options available to them that might be through the employer or another avenue. So we're really trying to push that message out there that even though the claim is rejected, it's really critical that somebody does continue on that treatment journey, because we do know that claims that do re-enter the scheme after that period of having the claim rejected going through the conciliation process, they often return in a much worse state than what they were at the start, and that makes it a real difficult challenge for the agent to manage. So, and yeah, absolutely, that process can be very detrimental and long. So that's why it really is important for that to continue.
Can I just ask, can you give us some sense of the proportions of how many claims actually get accepted with mental health claim and how many get rejected and how many go to conciliation, and then when they go to conciliation, what's accepted and what's not?
I can tell you roughly that it's about a 50-50 split. In terms of the numbers that go to conciliation, it's probably more likely to be a higher proportion. I don't have the exact numbers that do go, but probably in the 50-50 again. So, yeah, they're the rough figures at the moment. And obviously when we look at things specifically such as PTSD and other specific diagnoses, those figures might change. But overall, the general mental injury population, it's roughly half. Yeah.
So there's a fairly high proportion that are actually rejected outright when they actually lodge these claims?
Well, rejected possibly after further investigation or further interaction with the doctor in obtaining more information or through an independent medical examiner. So very rarely would they be rejected outright. Most of them are reviewed and looked into in that way. So it does require a bit of groundwork to get to that point.
And a fair chunk of them will be in the reasonable management action stage.
Correct, yeah. And that's, I think, where that expectation setting at the start around that is really important, because someone may feel as though that they've been impacted and have a genuine condition, but unfortunately the legislation just entitles that. Yeah. So I'll move on to the next slide if I could, thanks. This just gives a little bit of an indication of who you can talk to about the particular matter if you do need some more information. So obviously we spoke about the employer before as being a really critical part of this process. And within the agent, there's quite a number of people there that are actively involved in the management of the claim. So apart from the case manager, we've got the injury management advisor who is focused on the treatment and the health side, the return to work specialist who has an active role in working with the employer and the rehab provider to coordinate a return to work. We also have medical advisors out in agents who are doctors, and we would always encourage you, if you do want a peer-to-peer contact with somebody at the agent, to request to speak to a medical advisor, because they can obviously work very closely with the case manager with difficult clinical issues, and they can continue to speak to you throughout the journey of the claim if you feel you need that extra support. We also have the WorkSafe clinical panel, which is a supporting role in the agent activities. Recently we've had the clinical panel psychologists, which are beginning early intervention phone calls to other psychologists, and they also have a range of different allied health professionals working on that panel. We did mention earlier about the WorkSafe advisory service, so if you have any general questions, they certainly have got a realm of information that they can provide to you if you do need something answered. And something that I don't think we've mentioned previously, but we have an inspectorate that is focused on return to work. So what can happen is, if you are finding that the employer that you're working with your patient is not meeting their obligations and not providing those suitable duties, knowing that they might be available or there might be some issues there, we actually have a team that will actually go out and in an inspectorate capacity with the employer to work through any issues that they might have around providing that employment or being reasonable in their modifications of a job for somebody to return to. So,
Priscilla, is that just for accepted work cover claims, or can it be for any worker who feels they're being unfairly treated in the workplace?
For the return to work inspectorate, it is for accepted claims, but we do have another inspectorate for claims that may not be accepted at that point, and so the advisory service would be able to direct that call. But certainly if it is not an accepted claim, but the doctor feels as though there is something happening there that's untoward, certainly give the advisory service a call and they'll point them in the right direction.
So with the other one, I was talking to someone the other day from the clinical panel provider who coincidentally had 3 people in the same workplace all telling the same story about untoward things. So I just recommended we get in touch with the WorkSafe inspectors and they will decide if they want to do a visit.
Yes, absolutely. So we've just had a question come through. Can a GP contradict recommendations by an IME? I might hand that over to the clinicians, but certainly I think it's contextual.
Yeah. So you can certainly provide your own opinion, which may be different from the IME opinion. In practice, I think the agents worked, and this is where the agent's medical advisor or one of the clinical panel members sometimes gets involved and try and mediate between and come up with what seems reasonable in terms of the way forward with treatment.
So maybe someone writes a letter, there is someone at the other end looking at it and evaluating it.
Yes.
It's reasonable.
Yeah.
There might be more information that you have that's, as the GP,
unknown.
if you've known the patient for a long time, that would be particularly relevant that may not have been considered in that context.
Also, circumstances can change. There can be the intervention of another major stressor. I saw someone the other day where they were progressing okay, but then they had a major marital breakdown, which sort of stymied the progress from there a little bit. The other element of the question that came through was if you provide a certificate, I think, and someone, the patient goes to a new GP who gives them a different certificate of capacity, to what lengths will the IME pursue any relevant medical information? I think, Paul, that's perhaps Priscilla might want to add, but it is up to the agent if there's a new certificate, if it's contradicting other certificates and information, the agent may well pursue that in terms of requesting the other GP's clinical notes to try and make a judgment and get a better understanding of what's going on.
I would agree with you, Peter, and I think that's also something that the agent would work very closely with internally with the medical advisor and other resources they have available to them, because it is really a clinical issue around the change of diagnosis and possibly something that might have been triggered by a particular issue that they're unaware of, and I guess that's where asking for that information as to why that occurred or what have you would be really important in that instance to try and understand it a bit further.
And even in unusual cases, it might be the workers going and telling a completely different story to the other practitioners. Yes. So we need to sort of reconcile and try and find the reasonable way forward.
But I think it's sort of in the same vein, be careful how you write careful notes, because they are going to be reviewed.
Another question's just come through, and I might ask somebody on the panel to answer it. Does agent mean insurance provider?
Yes.
Yes.
WorkSafe subcontracts to, 5 insurers in the Victorian scheme who manage the claims from Victorian workers.
Okay, hope that answers the question.
So names like Gallagher, Bassett, Exchanging, etc.
All right.
So we might just tick over to the next slide. So this just highlights some of the services that WorkSafe offer. This is certainly not conclusive, but this is a real, high-level overview of the types of service, particularly for mental injury claims that would be applicable. You can find information on our website about each of these services, but probably the one that I would like to talk about is the Workplace Support Service, which is a revised mental injury initiative which is encouraging rehab providers to work with mental injury claims and the employer in a different way in what they would with a physical injury claim, in that it's really about bringing the parties together to work closely around what can be provided in terms of the obligations of the employer, and working a lot closely with them about identifying suitable duties, and also around mental injury functioning. So that falls under the realm of the occupational rehab suite of services, which under that is the vocational rehab services and also the GP return to work case conferencing phone call that we talked about earlier. So that's actually a phone-to-phone discussion with the employer that's arranged by the agent and or the OR provider. And there's a suite of other services there that you can find some information on, but certainly in the rehab space we do have quite a number of services that can be offered for.
OR was the occupational rehabilitation provider.
All right, sorry, yes, occupational rehab provider. Apologies for the acronyms.
And some of the rehab providers can be absolutely fabulous in the contribution they can make. A lot of them are psychologically trained and can assist greatly in returning to work.
So I think a question has come through around GP referring directly to WSS. It does need to be done in conjunction with the agent. So if you feel that is an appropriate service and something that you'd like to take up on, certainly let the agent know straight away, and they can get on arranging that in a really quick way. So
a couple more questions that we've got here. If you did a work-related psychological injury to a patient in your previous practice and you're no longer connected to that clinic, are you obliged to present to court if needed?
I believe so. That's more of a legal question, but I think the other side solicitors could well pursue you and subpoena you. You may be obliged to attend.
I'd assume that as well.
So it depends on your employer whether or not the former employer and the arrangements there. But yeah, what is the lag issue for claims acceptance, and when do payments commence upon claim submission and need to be repaid if claim denied?
Well, the agent has a legislative requirement to make a decision within 28 days. So in terms of when the claim is lodged, we often find that sometimes that somebody might not lodge the claim because they're not ready to. There might not be a lodgement made on behalf of the employer, a whole host of reasons. So once it actually lands at the insurer agent, then they will make a decision within 28 days, and then as of the date that that claim is accepted is when weekly payments can commence, provision to information being available to them to facilitate that, such as a valid certificate, employer meeting their excess, which is part of their obligations as well. So a person should expect to be compensated once the claim is accepted in a very prompt manner.
And the second part of the question, can money be taken off the claim then later stopped?
Can it be taken off?
Like if they've had a repeat independent assessment and there's no longer a work-related injury or whatever it is, if the claim ceases. The question was, can money be taken off the... Did I misunderstand the question?
Which one?
Yeah, I think they were saying, can money be... can you ask
Repay.
the patient have to repay money?
Denied, yeah.
Oh, no, the patient wouldn't have to repay anything, but what would happen is if there is a delay, for example, if the claim is rejected and then subsequently accepted, then the agent would be required to back pay as of the time that it should have been accepted.
Okay,
That makes sense.
yeah,
Yes.
it does. And what about for the claims that are in dispute? Who's going to provide payment to the treater if the claim is in dispute? So if it's interim or limited treatment acceptance, how does that work?
Medicare. Yeah. Well, in terms of the treatment, we would certainly say that Medicare is...
Or the patient.
Or the patient.
Patient would also, but obviously where possible, the utilisation of Medicare is probably the best. But obviously, that's an option available to the worker to be able to do that until such time as their claim is finalised. Then that's also an option.
I might clear through a few of these questions because they're pretty relevant questions. Somebody's asked, who do we contact at the workplace?
At the employer?
Yeah.
So I would generally say that most organisations would have a return to work coordinator or an occupational health and safety person, even HR, just depending on the size of the employer. So I think you'd probably find that HR would be the most appropriate avenue to go down to, who would refer you to the right person.
And often, in my experience, the employer knows exactly who you should speak to, so you ask them.
Okay. Can you involve a psychologist report to support your certificate of capacity?
Yes. We find increasingly, because under the Medicare system, GPs are relying more on psychologists to help their patients with mental health issues, and when we're having discussions with GPs, they'll often mention that they want to ensure that the psychologist is in agreement, because the psychologist may get to know the patient better in terms of some of the mental health issues. So absolutely yes. Okay,
here's an interesting one. Mining sector in the Pilbara region of WA has sacked a lot of last year or so. Significant numbers of the remaining workers come to the emergency department requesting work-related stress leave. Interesting that that's an emergency department consultation, but I'll throw my comment in there. At the same time, they fear losing their jobs and have a lot of mortgage and debts to pay. Anybody want to make any comments on that one?
I just from a purely, I guess, legislative perspective, that the perceived, or I guess it falls under that reasonable management action again, is that the perceived notion that something might happen to them does fall under that category of not compensable. If that was identified clinically as being the reason for them presenting, but there might be other things.
Probably where you'd want to go to the union, wouldn't it be? For one of the unions for some significant support in that context.
I think this is one of the examples where we're mixing up industrial versus with medical issues, and in some cases it might be medical, but on the face of it, it doesn't sound.
Somebody's just made a comment that I will read out. Sounds like work-related psychological injury cases are somewhat muddy waters. Is that the take-home message here?
No, there is some rigour and consistency in the decision making. It began because you can see a broken leg but not depression. But the research tells us that the consistency of diagnoses in the mental health space between, say, clinical psychologists and psychiatrists is about equal to what you get from radiologists. So it's not completely arbitrary by any means.
And I think that I prefer to use the word complex to muddy. It is complex, and I think the case example we've given today is a more complex case example. We did that on purpose because we thought the audience was at that higher level. A lot of them are more simple cases, but I think what we're trying to point out is that with thorough assessment and intervention, the muddy becomes a bit clearer.
And just, I mean, by virtue of the point at which the person often gets to you and raises these concerns is often several months down track after a whole lot of issues have, combined and added. So that's the complexities there in these cases.
Just while it's Ben Baresi again here, just while we're talking about additional services, I'd just like to redirect people to the WorkSafe website. There is actually a guide for GPs, which is now being uploaded for patients who are being bullied at work. It's now uploaded. So if you go to the WorkSafe website, /health professionals /general practitioners /GPs guide for patients bullied at work. And I'd also like to make a comment about the Return to Work case conferencing, which is also on the website, which you can look up the appropriate code, and GPs are remunerated for that for accepted claims. It's a very worthwhile service to use.
In the last few minutes we had left, we thought we'd just quickly touch on a couple other scenarios that we see not infrequently. We won't go into any specific detail, but just more as talking points, thinking points.
So the first one is Tom, who's a 42-year-old country high school teacher. He presents wanting sleeping tablets for poor sleep. When you take a little bit more history from him, he says that he's feeling very stressed and apprehensive at work due to an unruly classroom. He reports feeling he's experiencing panic attacks. He's quite ambitious and wants to further his career. So maybe just the panel can talk through some of the issues relating to a situation like this.
My first sort of quick comment would be Tom can certainly access a psychologist under a GP mental health plan, and I've seen people in similar spaces where that sort of 10 sessions with a psychologist concurrently helps perhaps Tom to get to a space where he gets clear about which way to go, helps him to understand better or develop better classroom management skills, etc., etc. So that's one option.
or perhaps there needs to be some employer support without necessarily work cover regarding the unruly classroom, and does there need to be a teaching aid, does there need to be an assistant, or something else. But some of the points that strike me about this case is that he's ambitious and wants to further his career. We often find that people in this setting are maybe more reluctant to put in a work cover claim, especially because he's in a country high school, everyone knows everyone, job options might be limited.
So move on to the next one.
So the next case is one that we also see a bit. Robin is a 54-year-old customer service operator. There have been concerns at work raised about her performance. She's been told she's making a lot of mistakes, she's not completing her tasks, she feels bullied again, a bit like Kim. She comes to you wanting to lodge a claim. The difference between her and Kim, though, is that you've been treating this lady for a very long period of time and her family, and you know that her husband has bowel cancer, he's recently had metastatic disease, her 10-year-old son's been bullied at school, you know she's had high levels of emotionality and been struggling for some time now. You'd already referred her to a psychologist, and she'd been commenced on an antidepressant medication earlier this year.
And I mean, this is where, from an employment perspective, there is an obligation to make reasonable adjustments. So if it's a reasonable employer, there may be adjustments in working hours to help her compensate for caring arrangements or coping with a domestic situation. So there's various types of leave that may be available. So that's, again, where maybe getting in touch with her permission, talking to HR on her behalf may be a positive thing.
There's a lot of pre-existing stuff here, though, Peter. I mean, how is this really about what's happening in the workplace, or is it more about what's actually?
No, I'm talking about not necessarily that there may be no issue of a claim because it's not related to work cover claim, but I'm just saying to help her manage the situation that's still contact with the workplace because the hours she works and the balance between what she's doing at home and at work may help her cope better overall. That's what I meant there.
And I think a lot of good workplaces will ask for an assessment of the fitness for duty.
Yeah.
Non-compensable. What do you do if she says to you, I want to lodge a work cover claim, please, for that certificate, doctor?
Well,
look, it's certainly it's the patient's choice to complete and go through that process. And obviously you have to exercise a little bit of judgment, and I think what you would do here is let them know what the actual process will be. So a lot of this information will be reviewed and will be a part of the process of whether the claim is accepted or denied.
That's right, and I'll ask for my medical notes, and then I'm obliged to give them to them, and they may know all about then your personal medical situation.
That does raise some other issues, family issues, and all that sort of information coming out as well. Yep.
So just to wrap up, we've got some contacts here for you to access. So we mentioned before about the WorkSafe Advisory Service. Certainly they can facilitate any questions that you might have on a more general sense. The inspectorate line that we mentioned earlier, which can also be done contacted through the advisory line, but if you do need to speak to someone from there, you can call them on that number. We've spoken about our links within the WorkSafe website. There's a lot of information on there that we've really encouraged you to access and have a look at, and particularly for GPs, the /GP is important to note there. And I mentioned earlier about the provider support clinical area, so their numbers there as well, and they've got a number of people that can help you with any clinical-based questions or queries that you might have, and also work with the insurer/agent if there is anything of particular concern that you do need help with in that space if you're not able to get through to them directly. And I think that's all for that slide.
Like to thank everybody for attending. I just want to remind everybody that there are CME CPD points available. Next webinar will be on post-traumatic stress disorder. Planning to hold that in early 2017. And I'd particularly like to thank Priscilla, DL, Peter and Ben, and the entire College of GPs, WorkSafe, TAC, support staff who have helped to assemble this and spend their time doing this. Thank you all.
Cheers, Michael.
Thank you.
Getting some really positive